Hi, I'm Dave Fornell, the digital editor for Health Imaging, and I have with me Brian Ghoshhajra. He is the division chief of cardiovascular imaging at Massachusetts General Hospital and an associate professor of radiology at Harvard Medical School. In the fall of 2021, there were new chest pain evaluation guidelines that came out and gave a 1A recommendation for cardiac CTA for a frontline evaluation and also for FFRCT. And I wanted to find out your thoughts on that.
I am obviously a big fan of cardiac CT. You probably get a similar answer to anyone that's dedicated this kind of time and training to develop expertise in this field. And there's a lot of us, and there's a lot of us from different backgrounds and different specialties that are in this field. We're all excited to have this as an option. There's been it's been slower to take root than one might have thought back when I was a radiology resident years ago. But the devilish details of this field are very important, and we've seen great strides, and a lot of people have done a lot of work to make sure that it can be safely done. So CT corneal angiography is a technically demanding specialty, and certainly a technically demanding exam to both perform and interpret. So there's been a lot of work to educate a workforce that can offer this test. It's still not widely enough available in many of our opinions. It's a disruptive technology, and I think that might have led to the only recent adoption into the major guidelines that we might have anticipated earlier. It certainly can obviate the need for invasive tests, but also might supplant in certain patients the alternative non-invasive tests. What we've learned, and I think is codified well in those guidelines, is that there's many best first tests for many different types of patients, and sometimes there's choices. We strongly feel that CT is often a first-line test, and more often than prior guidelines might have reflected. Not always, though. There's a lot of nuance, and it really is one of the most fundamental parts of the practice of cardiovascular medicine and cardiology and cardiothoracic surgery, is that imaging and the pathway that might lead to a therapy. So which therapy and can the therapy be as non-invasive as the imaging can now be is kind of the goal for all of us. So we're very excited, and I would say that the first line indication is highly appropriate in a larger and ever-growing number of patients.
And it seems to make sense that maybe over the last decade, 2 decades, that I can't think of an emergency room these days in a modern hospital that doesn't have a 64-slice scanner. So most of the scanners, I think, that are in these EDs are capable of doing cardiac scanning. And it seems to make sense that if you have a patient come in at 10 o'clock at night saying, I'm not feeling so well, and is it indigestion or is this guy having a heart attack? You could pull him on the CT scanner.
You're absolutely right. We find in our hospital that the time from triage at the front door to disposition after a negative CT, when appropriately selected for a negative CT, can be as low as 4 or 5 hours. And that counts time for blood work, time for ECGs. Most of the patients that we see for chest pain get those tests, but not all of them then turn into an appropriate CT patient. We certainly do a lot of it, but that being said, and we're, a lot of the research and some of that fundamental randomized control trials were done at our hospital, and our hospital led as a part of a bigger team for our second wave of randomized trials. But the fact remains, there's not a lot of interpretive skill for this. So the scans don't yet read themselves, despite what you may read in the in the lay press. So it does require expertise, both on the acquisition side as well as on the interpretation side. And I'll also offer that small workforce needs to be firing all cylinders during the day. So at certain points of the night, we can't yet offer 24/7 coverage, but these tend to be patients that aren't unstable. They're not having acute heart attacks that require immediate cath lab. So we can often hold those, especially you come in the twilight hours of the night. We might scan you first thing in the morning. At our hospital, we like to say you're never more than a day away from your coronary CTA. So I think it was in July 1st of 2014 that Dr. Meyerson and she was a fellow and I was the faculty, took the first call here, and we've operated 365 days a year continuously since then. But at 3 a.m. there's a good reason to rest the team that's still a small team. If you if you look at a hospital that's not lucky enough to have a deep roster, you might not find the interpretive skill yet. And there's a lot of hands on these CTs. So a technologist that's familiar with ECG gating. So even if you do have a 64 slice scanner, and I would argue that's the minimum price of entry, there's a lot more advanced scanners now. So not just number of slices, but the speed of the scanners or the type of iterative reconstructions, the gantry rotation time, and every little parameter should be maximized in certain ways for a coronary CTA. So we're lucky to have that available to us always and in multiple sites. So we now need the expertise. And so a lot of my job lately has been in training our affiliates to offer this. It's been really rewarding to watch this branch out, but there are sites that we cover that we're just getting rolling. And the way that we can disrupt in a good way that patient care is really rewarding. For instance, we cover some offsites on islands near Boston. There is no radio tracer supply on an island. There is no cath lab on an island. There's no stress echo tech. So if you want to do a workup that's that doesn't involve a helicopter ride, if you can put a cardiac capable scanner and get the expertise there, even if it means that they're going to digitally send me those images, then we can prevent that patient from taking what more often than not is an unnecessary life flight to a more expert center. So for me, that's an interesting, challenging challenge for the field these days, is to use a combination of teleradiology and education to get this technology pushed out to the community so that all patients can benefit, not just the ones that are closer to the centers with that expertise.
I believe that you're also using FFRCT, which is also included in the chest pain guidelines. And how does that technology help keep patients out of the cath lab or speed their discharge if they don't have a coronary issue?
The coronary CTA fundamentally is the test, and this is an adjunct in the subset of patients where there's an intermediate grade stenosis or a complex disease situation. So the fact remains about half of scans don't find any plaque at all. So there's some other alternative cause for chest pain. So we don't need to put an extra shine on that. The negative predictive value of a CT angiogram that's a high quality CT angiogram interpreted with the right expertise is extremely high. And so the value add comes in, and also not in the most severe stenoses where it's very obvious. It really comes down to that an intermediate grade lesion where there's a stenosis, but it's hard to predict the physiologic consequence. And it turns out that even in the invasive angiography lab, it's not always possible to visually predict stenosis grading. We've known that for a while through a couple of trials, whether it's the FAME or the DEFER trials. But the idea would be that what needs to be done invasively with a flow wire can be predicted virtually with reasonable accuracy using computational fluid dynamics. And I think most experienced cardiologists, especially interventional cardiologists, will tell you that everyone knows the lesion that doesn't look all that bad, but there's just something about your gut that tells you it might be positive. And certainly CT readers find that to be true. Anybody that's done this for any duration of time will tell you a series of stenoses is a really dangerous thing and should be very carefully considered, even though it may not be all that severely stenotic, might actually turn out to be a flow limiting situation. So now we have a test that we can turn to when we end up in that situation. And we can do that virtually after the scan is done. And that's how we do it. We find it pretty useful in about 9-10% of the patients, which is a not insignificant number when you look at all patients being scanned. So of those patients, a little over half we can actually feel good about not sending any further testing. I think I'd add that the guidelines are a really nice start. I also like the way the guidelines have been revised, since chest pain is not always the symptom. I think we've learned a lot about the underdiagnosis of heart disease in women in general. And I mentioned that there's the field's always evolving. We know a lot more about spontaneous coronary dissection and some of these other causes that are non-atherosclerotic of chest pain. There's a whole field around INOCA and MINOCA. So, myocardial infarction with quote unquote normal coronary arteries that really aren't normal, but angiographically might be. So I think the guidelines put a nice roadmap out there, but they're just a start. They're incomplete. And they're always evolving. But anyone that's looking to serve their patients best, I think it's a wonderful place to start. And if you don't have access to CT angiography for those patients in which it's appropriate, I'd ask you why. And I would challenge you, the community, to get that access to your patients.
Do you think CTA is going to become more of a standard of care within the next 5 to 10 years?
I would say we've been there and probably for 5 years in our hospital. But again, we're at a tertiary referral facility. But usually the way the practices evolve here is the way that the rest of the world goes. And I think the guidelines just codify that. I think 5 or 10 years, maybe even too late. I think we can probably expect that to happen very quickly.
Appreciate your overview.
Thank you.